Right. Yes.
Dr. Pettigrew, you were telling us before lunch about the process of telling parents, in particular mothers, about their child's diagnosis. What, if any, arrangements were made by York Hill for the children themselves, subject to obviously to their age, to be told of their diagnosis?
Richard, do you mind, before I answer that, if I could add something that I hadn't given in my earlier responses, and I apologise. The first thing was, when you asked about what steps were taken to reduce the risk after 1983 when Dr. Han came, I omitted to mention that obviously the use of DDABP in situations where it was appropriate, and probably less important, but I think I should mention that other lifestyle advice was things like no intramuscular injection, no aspirin, regular dental care, making sure that the muscles around the joints were kept in good condition by appropriate exercise. So I do apologise. So you were asking about arrangements to tell the children.
Yes.
Yes. Well, the sort of practice in those days was that the parents would be told first. I think I mentioned in my Penrose statement, and possibly it was before the 1985 or 1988 Children's Scotland Act and the 1991 Children's Capacity Act. And the parents were then asked whether they would like to tell the children, or if they would like us to tell the children, either with them present or not. We recommended particularly that the older children be told, because obviously some of them would be approaching puberty, and then there would be other issues that were important to discuss, like sexual transmission. So that was the basic policy at the time.
And
sorry, for children who are being treated for other hematological diseases such as leukemia.
And were there children who child patients who you told their diagnosis to, or did parents tend to do it themselves?
I think parents tended to do it themselves, and I cannot say with any absolute certainty that I didn't tell some of the children, but I think on the whole parents tended to tell the child themselves and choose when they told the child or when the child was told.
I think you're aware that when Dr. Mark Winter gave evidence on the issue of whether to tell children their diagnosis, he referred to having had some form of dialogue with a group of Scottish clinicians who didn't favour the child being told their diagnosis. Do you have any knowledge of that?
No, but I heard Dr. Winter's evidence, and I checked Dr. Han's evidence, and I think the meeting was quoted as a UCHDO meeting in 1984, but Dr. Han was not at that meeting, and I think he was asked in his oral evidence to Penrose about policy, and I don't think, I'm pretty confident it wasn't our Scottish group that was at that meeting.
If we could have up on screen WITN 3527003, please, Shumik. This is a letter from the GMC. I'm not asking you anything about the details of the issue being considered in terms of the individual patient or the process. There's just one thing I wanted to ask you about, Dr. Pettigrew. It's in the last paragraph on this page, where it said, by reference to an HTLV3 result, the result was found as part of a research project, and Dr. Pettigrew was passing on information in order that a clinician could arrange for appropriate measures to be taken. Can you assist us there with the reference to it being a research project which revealed the HTLV3 results?
I have to admit, I think I was just so relieved when I got that letter after the case took 2 years to resolve at the time. I didn't really notice or take full cognizance of that phrase there, and I was reading it obviously in preparation for today, and I thought that's not correct. It wasn't a research project. I think they must have misunderstood, and there was certainly nothing in the letter that was sent on my behalf by the MDDUS. There was no reference to a research project.
Okay. Can I just ask you a little about the benefits of the social work input that York Hill had at this time? A social worker, Christina Leitch, had joined York Hill, I think, in the autumn of 1984. To what extent was her involvement an important aspect of the support for parents and children?
I think Mrs. Leitch's involvement was pivotal. It was very, very important, because she was somebody that was not directly, well, she was part of the haemophilia team, although she wasn't a haemophilia social worker. But she was out with the clinical area of treating patients with haemophilia, and I think her input was very important, because certainly the parents could discuss issues with her which they may not have liked to discuss with us. They could express their emotions, their anger, their concerns, their own difficulties with her that they may not have expressed with us. And I think it was very important. And I noticed in her statement to the Penrose inquiry, she said that the medical staff were reluctant for her to set up parent support groups, and that certainly wasn't my opinion. I was very grateful that she was able to do that.
In terms of the arrangements that were made for the treatment of children infected with HIV, your statement explains that they would be referred to the infectious disease unit at, I may pronounce this wrong, Rook Hill Hospital? Rock Hill Hospital for continued monitoring. What were the arrangements as between York Hill and the infectious diseases unit?
Well, as far as the care of patients with haemophilia who were HTLV3 positive, there was a very close liaison between the two units. And also, Rock Hill did have paediatric patients. I think I said that in my statement. You know, children were admitted to Rock Hill with infectious diseases. But we liaised closely with the infectious disease specialists at Rock Hill, because they had experience of treating patients with AIDS, even at that time, because there was a number of members of the gay community, and also at that time in Glasgow there was quite a problem with people who inject drugs. So they had certainly more experience, and a lot of experience of treating patients with AIDS. So we liaised with them, and we cared probably on a sort of joint basis for the patients.
What was the division of responsibility between York Hill and Rock Hill?
The Rock Hill would give advice on any treatment for AIDS. Initially at York Hill, we would monitor the boys for any symptoms of any AIDS-related disorder. I think we also took the blood for them, on the advice of Rock Hill, for the CD4, CD8 lymphocyte ratios, and would inform probably, I think it was Dr. Kennedy at the time, of those results, and we would take their advice on any action that needed to be taken.
And at what point in the development of a boy's condition would they actually be attending the infectious diseases unit and receiving treatment there?
I'm not sure. I know that they did attend infectious disease unit and at the clinic there, but I couldn't tell you exactly when in their condition. I know certainly by the time that any of the boys were commenced on any form of treatment, they had been attending a clinic at Rock Hill.
Do you know what, if any, efforts were made to minimise the potentially very negative effects of children with HIV having to attend Rock Hill for treatment and be exposed there to very ill patients and IV drug users and so on?
Well, I think we tried to monitor and look after them as far as we could in York Hill. And I can't really speak for what measures would be taken in Rock Hill to try and minimise their contact with not only very ill patients, but also some perhaps difficult patients, considering the group of involved using, who were people who were injecting drugs.
Do you know whether any representations, for example, were made by York Hill to Rock Hill to see whether there could be some kind of separate arrangements or separate clinics or attendances for the York Hill children?
I don't know of any such arrangements, but as I said, I know that Rock Hill were used to dealing with children who were admitted there with infectious diseases.
You've referred in your statement to the stigma associated with HIV at this time, including from hospital staff themselves. Could you perhaps elaborate upon that, please?
Well, I think the thing that springs to mind there is an announcement by, before any of our patients were found to be positive for the virus, an announcement by the porters that under no circumstances would they either transport in a wheelchair or a trolley patients who were known to have the AIDS virus in the hospital. They wouldn't transport them in the hospital, whether that would be for X-ray or whatever, and on no account would they transport any deceased patient. And also, you're aware from witness statements of the way that patients were, our boys were treated when they were admitted. And that obviously made them feel quite stigmatised too, and it must have been very difficult.
Your statement to this inquiry refers to GPs initially not being told of the diagnosis of HTLV3 HIV because of the surrounding stigma and hysteria about AIDS. Is that correct?
That's correct. And I think we did eventually write to GPs, but we put on the envelope to be open, highly confidential, to be opened only by the general practitioner to which this is addressed. And I think most general practitioners would have taken steps to keep that letter in a secure place.
Was that done only with the agreement of parents, or were GPs notified in the absence of parental agreement?
I can't be absolutely sure. I would think we would have informed the patients that parents that we were writing to the GP. But as I said in my statement, when I was in general practice, it was accepted that patients who were known to have HIV, that the GP didn't have to be informed, but obviously the patient took that decision themselves, and not the clinician.
In her statement to the Penrose inquiry, the social worker, Christina, gave evidence referring to a concern expressed by a colleague of hers that children with bleeding disorders were generally treated like second-class citizens as inpatients. We can look at it if you need your memory prompted in relation to that.
I remember reading that. And my thoughts at the time were, well, perhaps to a certain extent that was true, probably from the point of view of, well, first of all, could I say that the sister who ran the ward would not have tolerated any distinction between the patients. But in the ward 7A, and it would have been ward 7A at that time, which was the haematology ward, there was a lot of, the parents of children who were being treated for leukemia were there living in the ward for approximately 4 to 6 weeks during the very intensive induction phase of treatment for leukemia. They would get to know each other well, and they would form a little group. And I think they would probably not have included any parents of children with haemophilia in that group. And as I think Christine Leach said, that they tended to see these children as being relatively healthy if they were in for with a bleeding episode. So I think to certain extents that would be true, but I would have to say that the nursing staff, I think, would do their best not to make any distinction between, because they were all sick children and to be treated equally.
What advice, as far as you can recall, was given to parents, family members about the infection risks?
Well, I remember at the time, probably from MMR, but there was only one incident where a carer had been infected from a patient who had AIDS, and that carer had a lot of exposure to bodily fluids and had, I think, possibly eczema or something, where there was open areas in the skin. But apart from that, there was no evidence of any spread to household contacts. However, we did reinforce the advice that we'd already given about preventing transmission of viruses such as hepatitis B, and particularly when home treatment was being performed. So we reiterated that advice strongly, and things like not sharing toothbrushes, not sharing towels, etc.
Dr. Pettigrew, before I turn to the handful of further topics I want to cover with you, there are some further questions or requests for clarification arising out of your evidence this morning. I asked you whether parents were given a choice to go back onto Cryoprecipitate in 1983 and 1984, and you answered by reference to two parents who asked to go back onto Cryoprecipitate. Does it follow that was of the parents' own initiative?
I think you could probably say that, because I don't think there was any policy to wholesaledly up to change everybody who was on home treatment to Cryoprecipitate.
And why was that not offered to every parent?
To be perfectly honest, I'm not sure. I think it was because the feeling was that Cryoprecipitate wasn't suitable for home treatment.
Can you recall what reasons were given by the two parents that you've remembered for wanting to revert to cryo?
It was their concerns about the risk of concentrate, particularly with HTLV3, despite the fact that we were using NHS concentrate. I think they were concerned that it obviously wasn't completely free of risk, and that cryo would present a reduced risk.
And then I want to go back to the question of what information was given to parents if they expressed to you or Dr. Han their concerns about the risks of AIDS in 1983 and 1984. Did there ever come a time when you told parents that it was indeed likely that AIDS was transmissible by concentrates?
I think there probably was a time that we would have to tell them that. I can't give you, I can't recall, actually occasions where I said that, but, as I said, we gave them information on the knowledge that we had at the time, and obviously as time went on, it was obvious that AIDS was transmitted by a virus, particularly through concentrates, particularly through commercial concentrates.
But is this right? You're not able to tell us when that time was reached?
No. And I say I can't remember specific conversations.
Did there come a time when parents who expressed their concerns to you or asked you about AIDS were told in terms that if their child were to be infected and developed AIDS, the prospects were that their child might die?
Yeah, well, initially, obviously, when we told them initially about being HTLV3 positive, we had to indicate that at that point we didn't know how many of those patients who were HTLV3 would go on to develop AIDS. And I think it was well known, it was common knowledge then, I think, that patients with AIDS tended to die. Whether we would have said, at that point, and if your child develops AIDS, they're going to die, I don't think we would have said it at that point.
Can you recall when the practice of marking samples, serum samples as high risk, was introduced at York Hill?
Well, I know it was a practice when I was working at the Royal, and probably before that at the Western, that if you suspected that patients were at risk of, in those days, hepatitis B particularly, they were marked as high risk. So all specimens from patients with haemophilia who'd received blood products would be marked as high risk. And that policy ceased when it was considered that all specimens should be considered high risk later on.
Then I want to go and ask back to the question of the facilities at York Hill. How was the move to the new facility from the initial unit that you've described funded?
I think probably Dr. Han would have a better idea, but I think it was funded through the health board. It wasn't funded through donations or whatever. I think it was a health board not initiative, but a health board funded project.
What about the nursing sister position within the haematology service? Do you know how that was funded?
Yes, that was funded through the hospital. She was an employee of the hospital, and I have to say, well supported by nursing management when it came to nursing management informing her of any appropriate meetings there were for nursing professionals involved in patients with who were HTLV3 positive.
You referred earlier to a Leukemia Junior Research Fellow. Do you know how that individual's position was funded?
I presume the Leukemia Research Fund.
Okay. And do you know what kind of research they were doing?
Well, all the children who were being treated for leukemia were treated according to the national leukemia trials. So UK ALL, UK acute lymphatic leukemia trials, which set out the treatment at the time, and then the treatment was modified depending on success of that treatment. So when you say research, they were really involved in the care of the children with leukemia, but those children would be part of UK ALL trials.
You've told us that you were aware of in 1980 and parents would have been told about the risks of hepatitis B. What was your understanding of those risks in 1980, in the early 1980s? And what did you say to parents about the hepatitis B risk?
Well, obviously I was aware of hepatitis B because it was something that I would have learned about as an undergraduate and a postgraduate in preparation for MRCP exam. Parents were told that all blood products carried a risk of being infected with hepatitis B, and even after screening, the screening was not always, that didn't always pick up every case of hepatitis B, and that there was a risk. And obviously hepatitis B could in some cases be a very serious and occasionally fatal illness. And that's why we monitored them for their hepatitis B status. And also knew that some patients could become carriers without developing illness.
Was there any kind of system or systematic approach for explaining to parents whose children were going to go on to prophylactic home treatment what the risks were?
The risks of hepatitis B?
No, sorry, more generally, what the risks of prophylactic home treatment were?
I don't think there was any systematic, there wasn't as far as there wasn't a policy in place.
In terms of such parents to whom you would have been introducing home treatment after 1980, can you recall if it was your practice to tell them about the possible risks of developing inhibitors from prophylactic treatment?
I think we would have advised them about that and that we would monitor for that. I don't think, I'm not sure if any of our patients did. We might have had possibly one patient that developed an inhibitor, but in York Hill, we were fortunate that we didn't really have a problem with patients developing inhibitors.
Were parents told that prophylactic treatment was something new and unusual and different from what was being done at other centres?
I don't know if they were, and I wasn't. I knew it wasn't. Well, when I came to York Hill, there wasn't a home treatment programme at the Royal, so I wasn't aware whether it was unusual or not. And as I say, Dr. Willoughby introduced it after, reading papers published by haematologists elsewhere.
You've told us that very young patients and patients who hadn't previously been treated with concentrates would be likely to have received cryoprecipitate if they came to the hospital for treatment. Was the reason for that because cryoprecipitate was believed to be safer for such patients?
I would have to say in Dr. Willoughby's day, I would have to presume it was. In Dr. Hand's day, it certainly was. So I can't speak for, because Dr. Willoughby, as you see from his statement, although he knew that there was an increased risk from concentrate, I don't know if, I think true part of it was that in the very young children, cryoprecipitate was a smaller volume. So it could be used rather more easily than larger volumes in other children.
So is this right? You're telling us you don't know what Dr. Willoughby's rationale would necessarily have been, but you.
I don't.
But insofar as Dr. Hans was concerned, you understood it was because that cryoprecipitate was safer.
Yes.
In terms of liver function tests, when did you first become involved in testing patients' liver function?
I think probably not long after. Well, when I arrived at York Hill, probably not long after, and I think I probably would have said to Dr. Willoughby, when I was working at the Royal, we were checking liver function tests, and if do you mind if I check them in our patients?
So until your arrival, that wasn't being done at York Hill?
I don't think it was being done, no.
What did you tell parents about the liver function tests and in particular the results and the levels?
Well, as I said, when I was taking the blood, I would say, we're checking for your hepatitis, your bacterial levels, your blood count, and for liver function tests, because we know that some patients with haemophilia have slightly abnormal liver function tests, and we would like to just keep an eye on that. As I say, I can't recall any of our patients having liver function tests that were abnormal to a degree that one would have concern. And it may be that it was intermittent and we might have missed abnormal liver function tests.
I'm conscious you didn't have very many von Willebrand's disease patients, perhaps only one at the beginning of your time at York Hill. Were the ALT levels of von Willebrand's patients also measured?
I suppose if we were checking routine bloods in von Willebrand's patients, as it was part of our normal procedure, we would have checked liver function tests as well.
You've referred, when I was asking you about Ruckhill Hospital, to knowledge of there being an IV drug user community in Glasgow. When did you become aware of the problem of AIDS amongst needle-sharing IV drug users in Glasgow?
Well, I think it probably would be in '84 sometime. I couldn't tell you exactly, but I think it was something that was quite well publicised.
Moving on to 1985, in the period from 1985 to, I think, the spring of 1987, the factor concentrate that you were using for the treatment of patients would, as I understand it, have been the SNBTS heat-treated product, NY. Is that right?
Yes, that's correct.
Now, that was understood to eradicate HTLV3, but not non-A, non-B hepatitis. Was that your understanding?
That's correct, yes.
So the children would still have been at risk of being infected with non-A, non-B hepatitis during that period?
Yes, but as you know, the consensus of opinion is that patients who are infected with non-A, non-B hepatitis would have been infected at their first exposure to concentrate. And when the heat-treated concentrate was introduced, I would explain to parents when I came back from maternity leave probably, that we were using the heat-treated concentrate because it was thought to, or it was known to inactivate the virus that caused AIDS. But I also did say to them that at the present time, it did not appear to inactivate whatever the virus was that was causing the abnormality of the liver tests.
What about the position of patients who had not hitherto been treated or been only minimally treated and therefore might not have been exposed already to non-A, non-B hepatitis? Was there a system or policy in place for ensuring that such patients didn't receive NY unless absolutely necessary?
I think Dr. Hand's original policy would still be in place, which would be cryoprecipitate for, although it's a sort of difficult because, cryoprecipitate may still have had some risk of transmitting AIDS, although very minimal. But as far as I recall, I think his policy was still in place, but I can't be absolutely sure.
Can you tell us anything about the approach to the treatment of patients with Haemophilia B in 1985 prior to the availability of heat-treated factor IX concentrates?
I can't really. I presume we must have had to continue them on the NHS concentrate, but I can't really remember, Mr.
You talked in your statement about the approach to consent in the 1980s and talked about consent being implied, consent to treatment being implied rather than express. Can you assist us with what you meant by that?
Well, I think as was common practice then, if a parent brought their child in for treatment, and in situation with haemophilia, the treatment was obviously, they would know what the treatment would likely to be. And you would say, well, I think we need to treat this bleed with whatever. Unless they actually said no, you would understand that they were agreeing to the treatment.
And
I think the implicit or implied consent.
In the course of the 1980s, during the time you worked at York Hill, was consent to treatment or consent to testing ever recorded?
I don't think it was practice in those days to record consent. I mean, you would record bloods taken for whatever, but I don't think it was common practice to record consent given to treatment. You would record treatment as well.
And again, in that period, 80 to 89 at York Hill, did there ever come a point at which written information about the risks and potential consequences of treatment was provided to patients or their parents?
I can't be absolutely sure. I don't think so, but there might have been. I can't remember.
When a patient moved from the care of York Hill to the Royal Infirmary in Glasgow, would their records of treatment at York Hill normally be transferred to the Royal Infirmary?
No, they wouldn't. The records from York Hill records were kept at York Hill, when the patient was transferred, a letter would be written to either Professor Forbes, Professor Lowe, whoever was the director at the time, outlining what treatment the patient had received and what relevant blood tests had been and results. And any other relevant information would have been sent in the letter.
Did you ever have any further contact with Dr. Willoughby after he left at the end of 1982?
No, I didn't.
And were you ever contacted about any fatal accident inquiries into the deaths of any of the boys at York Hill?
No, I wasn't.
In hindsight, Dr. Pettigrew, do you think that Dr. Willoughby's treatment policy, involving as it did giving children large amounts of commercial concentrates, paid sufficient attention to the risks of infection?
I'd have to say, first of all, that Dr. Willoughby instituted his programme of home therapy and prophylactic therapy with the intention of providing a better quality of life for his patients and their families, and also to prevent the morbidity and mortality of haemophilia. So he gave treatment in good faith, and I think from reading his statement at the time, without being fully aware or without realising the severity of the potential risks involved. I think it would, in hindsight, yes, it would have been better if he hadn't used commercial factor VIII concentrate, if perhaps there had been sufficient supplies of SNBTS concentrate to treat these patients. But unfortunately, that wasn't the case at the time, or didn't appear to be the case at the time, and these children were treated with quite a lot of commercial concentrate with the subsequent terrible consequences.
So that completes my questions for Dr. Pettigrew, but can I invite you to take a break so that core participants, recognised legal representatives, have an opportunity to suggest any further questions they would wish to be considered?
Yes, certainly. How long do you think you might need?
Well, I've already had some questions which I've factored in already over the lunch break, so I think perhaps 20 minutes, 25 minutes would be sufficient.
Yes, well, let's take a break in that case until 10 past 3. Dr. Pettigrew, the reason for this is that obviously there are people watching online who are in virtual communication only with counsel, who have the right to pass questions for her to consider whether she should ask them to you or not.
Yes.
And in order for that to happen, plainly there has to be time and discussion. So I'm sorry for taking a little bit longer than you might have expected this afternoon, but nonetheless, that's what we'll do. And we'll come back at 10 past 3 if that's okay.
Thank you, Sir Brian.